But I'll tell you that multiple myeloma, when you compare it to the breast cancers, the lung cancers, the colon cancers of the world, is a much more rare diagnosis. And so, what that means is you want to make sure that the person who's treating you sees multiple myeloma frequently.
And we'll be asking you 20 questions. So,
Okay, I'm in the hot seat.
yes. Are you ready?
I'm ready.
All right. So, please introduce yourself, including your name, title, and any affiliations you may have.
Perfect. So, this first question I think I got correct. I think I can answer this one. So, I am Dr. Brandon Blue. I am an assistant member of malignant hematology at Moffitt Cancer Center in Tampa, Florida.
Great. Thank you. So, the first question is after multiple myeloma, will my bones ever strengthen back to normal again?
Yeah, so unfortunately, up to 80% of people who have a diagnosis of multiple myeloma unfortunately have some type of bone disease. So what happens is that the bone damage happens actually from active cancer. So once you start on therapy, the good news is that the cancer is now out of those bones, and unfortunately, a lot of those bones just never heal. Even though there's no more damage being done, unfortunately, the damage sometimes is just irreversible. However, we do try to strengthen the bones by giving certain medications that your doctor can talk to you about. But unfortunately, sometimes the bones just never get back to their precancerous state.
And how do you know if a stem cell transplant or CAR T cell therapy is better?
Yeah. So they're basically two different options and used for two specifically different reasons. Let me give you an example. So the reason that patients typically go for a stem cell transplant is once their disease is under control, typically stem cell transplant lengthens the period of time that someone's disease is in what we call remission. So the first step is to get the cancer from at a very high level down very low. But once it's low, you want it to stay that way. And so that's where stem cell transplant comes in to try to lengthen that period of time that the disease is under control before it comes back. Now, that's quite different than CAR T. CAR T is actually used when the disease has actually relapsed, meaning that we don't typically give CAR T for people whose cancer is under control. We actually, unfortunately, give it as a treatment or a therapy when their cancer has relapsed to bring it under control. So they're used for two specifically different reasons.
Is there a connection to an AFib diagnosis after receiving a diagnosis of multiple myeloma?
Yeah, so unfortunately, atrial fibrillation happens when the heart is stressed. And unfortunately, there's a lot of reasons for your heart to be stressed when patients have a diagnosis of multiple myeloma. For example, one of the main kind of complications of multiple myeloma is people developing low blood counts or something called anemia. When you have anemia, that means that there's basically less red blood cells circulating in your body. Well, guess what? If the heart is a pump that's supposed to pump blood, but there's less red blood cells, then guess what that means? That pump has to just work harder and harder. And like anything, any good muscle, it just gets stressed if you work it too hard. So there is a increased association there. Also, with certain chemotherapy medicines that also put more stress on the heart. And so, anything that can really put stress on the heart really can increase the risk for atrial fibrillation. So, unfortunately, yes, there is a risk that is there.
Can you be eligible for CAR T cell therapy if you're in renal failure?
Yeah, so renal failure is not an exclusion for patients to get CAR T cell therapy. We do it to patients. So sometimes, unfortunately, when patients' kidneys don't work, they need something called dialysis, which is basically a machine that can actually filter the blood, which is the same role that the kidneys would do. It's just this time it's the machine that does it for them. And so we have patients who are actually on dialysis who still receive CAR T cell therapy.
What is a tandem transplant? Are there situations where you do tandem transplants?
Yeah, so sometimes what happens is once the disease is at its very newly diagnosed state, when there's so much cancer there, we try to get the disease under control. And then the next step would be to move to what they call a stem cell transplant. However, there's some data that shows that there's some patients who not only get one transplant, but then they turn around and get a second transplant right after. That's called a tandem, meaning they get the disease under control and then transplant one, followed by transplant two. And there are some very unique circumstances that is being done, but I will tell you that as of 2024, it's becoming less and less common.
Does neuropathy get better after taking Velcade or bortezomib?
Yeah. So unfortunately, that's one of the best drugs, I'll say. I'll say fortunately at least, that's one of the best drugs for multiple myeloma, but unfortunately, it has one of the stinkiest side effects, unfortunately, that neuropathy. And I'll tell you that the neuropathy can actually be two-sorted. Sometimes it can be this pain and tingling sensation, but in the other times it can also be kind of numbness. And so with that, sometimes once we either dose reduce the Velcade or bortezomib, or even just stop it altogether, there is a percentage of people who actually do improve. Now, the question will be, will you improve all the way so it goes all the way to zero? Possibly, but typically there is a significant benefit once you either dose reduce it or stop it if you tell your provider early. So that's the key is that once you first start feeling that, hey, I might be having some neuropathy or something's not right, you want to make sure that you bring it to your provider's attention.
If I'm not on a 3-drug regimen, should I be concerned that I'm not on a 4-drug regimen?
Yeah, great question. So, one of the things that is very important with multiple myeloma is that there's so many different options. And because there's so many different options, what we can do as the providers is to actually hand pick a specific regimen that works best for you as a patient. So, you say, what does that mean, Dr. Blue? If you look at the person who's literally right next to you, they could have the same multiple myeloma diagnosis, but be on different medications. And so there are certain reasons that your doctor may choose and say, you know what? I think based off of your specific case, drug A and B might actually work best for you, as opposed to someone literally with the same diagnosis, drug C and D would work best for them. So I think it's all a conversation. And I think there may be some nuanced reasons why your doctor chose those regimens. So I would just say have a conversation with your provider and just try to make sure that if there are questions about why they chose those certain medicines, typically there is a reason. So you want to just have that conversation and be open about it.
Being that drugs are so advanced these days, should the standard of care not be transplants?
That's a great question, and that's actually one that's currently being researched. So typically what happens is that us experts, we all use our brains to try to figure out how do we make things better for patients. But just because we have an idea, we have to test that idea through research. And then after we test that through research, that's how we lead to changes within the current standard of care. There's been a lot of different things that people have thought of that could potentially beat transplant and say, hey, we know that transplant is kind of a heavy ordeal. Maybe this will be better or that will be better. But nothing so far has actually been proven to be better than transplant as of yet. But there's a lot of things that people are thinking about and trying to be very creative with to try to prove that. So there's a lot of research that's going out right now. But as of what's approved as of 2024, unfortunately, there's nothing that has been able to beat it yet. So it's still considered what we call standard of care.
How important is taking vitamin D supplements for patients with multiple myeloma?
Yeah. So as I mentioned before, up to 80% of patients who have multiple myeloma actually have damage to their bones. So, what that means is you want to be on medications that can help strengthen the bones. We know that not only vitamin D is important, but also calcium. So, calcium and vitamin D typically work together to help strengthen bones. So, we always recommend that patients have some type of extra medicines that continue to make sure that their bones are as strong as possible during their lifetime.
How do you recommend getting second opinions? Would you necessarily need to go to a different practice or institution?
Yeah. So what I would say is that everyone who has multiple myeloma needs to typically see a multiple myeloma specialist. You say, why is that? There's a very lot of different reasons why someone may have cancer. Some people may have breast cancer, some people may have lung cancer, some people may have colon cancer, and some people may have multiple myeloma. But I'll tell you that multiple myeloma, when you compare it to the breast cancers, the lung cancers, the colon cancers of the world, is a much more rare diagnosis. And so, what that means is you want to make sure that the person who's treating you sees multiple myeloma frequently. And so, if your doctor already does that and they say, hey, um, we see multiple myeloma every day, then you could probably guess that you may be in good hands. However, if your doctor maybe sees multiple myeloma once a year, then we always recommend that you probably see a doctor who is considered a multiple myeloma expert and likely sees multiple myeloma a little bit more frequently.
How is it known which target to attack? Example, CD38 or BCMA, etc.
Yeah. So the good news is that we have options for this disease. And so there are a lot of different options. And so there's a lot of different nuances to why certain drugs are typically used in what order. So this is a what we call a patient-specific answer. And so one of the things that we're fortunate enough to have in multiple myeloma is actually personalized care, meaning that this is something that could be very specific for your specific type of cancer of why we would say, hey, you know what? The next step for you might be A, but the next step for the very next person might be B. So that's a very personalized answer. And I would say talk to your provider because again, the good news is we have options.
For relapse myeloma, what is typically the recommended order of treatment options? Is it bispecifics, uh, stem cell transplant, or CAR T cell therapy?
Yeah. So again, as we talked about before, multiple myeloma has a lot of different options. Okay. Typically, when someone is newly diagnosed, that's typically the preferred time that patients actually get the stem cell transplant because, again, the stem cell transplant is typically not recommended in what we call the relapse setting. All right. So at the initial diagnosis stage, patients get their disease under control with a 3 or 4 drug regimen. And then they move to step two, which is the stem cell transplant that leads them into a long remission. After the remission is over, meaning that the disease has now relapsed, now you're on to these new therapies. And depending on exactly how your disease has relapsed, will depend on what that next line will be. For example, there's some patients who, after their remission, their disease is going up so slowly. So we have plenty of time to think about what the best next step should be. On the other side, there are some patients that come out of remission and their disease is shooting up like a rocket and moving so fast. So we have to be very strategic about what we're doing because literally days matter. So again, that's something that is very specific on your type of disease.
What is the most effective way to manage bone pain in multiple myeloma?
Yeah, pain is one of those things that's so subjective. For example, there's some people who have bone disease, but they walk around and say, "Hey, Dr. Blue, I feel fine." And then there's other people who unfortunately have less bone disease, but they are unfortunately in a wheelchair. So the one thing to know about multiple myeloma is the average age of diagnosis is at 69. So most of the patients who have this disease are older. Are the older population. And so what we know is that not everyone's um, um, biologic age is really the same. So, for example, there's some people who are 70 years old who, unfortunately, their body may have certain what we call comorbidities or other health issues that unfortunately may make them seem like a 75 or 80-year-old, as opposed to there's some people who are 70. You're like, oh my gosh, this person, has the body of a 60-year-old. So again, they can be very complicated, but I will say that there's a lot of nuances to that answer.
How are blood transplants done and how long is the recovery period?
Yeah. So typically what happens is that we all in our bodies make new blood. The same way we make new hair, we make new fingernails, we also make new blood. And the place that we make new blood is in our bone marrow. You say, well, how do we do that? We do that through these things called stem cells. And so, what we're able to do is that we give patients high doses of chemotherapy that can really kind of cleanse the bone marrow because, again, multiple myeloma is a bone marrow disorder. So, after we've cleaned the bone marrow, now the bone marrow is empty. So, you say, well, I can't live without a bone marrow. So, what do? we take those seeds or those stem cells and we plant them in the ground. And now they grow and they make new blood, just like seeds would get up and grow and make new flowers. Unfortunately, it doesn't happen overnight. So typically, we tell patients that you should expect somewhere about 3 to 4 weeks of recovery during that whole process.
How can CRS side effects be treated?
Yeah. So let's talk about that for a second. So one of the things that is a known side effect of CAR T cell therapy is what they call CRS or cytokine release syndrome. And so this is something that is a new treatment because CAR T is relatively new. But the good news is that we think that we've got it mastered. And so we have different ways to treat CRS or cytokine release syndrome. There is a medication that is called tocilizumab that works extremely well at decreasing CRS related side effects. But also sometimes a simple Tylenol will work. So it kind of depends on exactly what's happening at the time. But there's a lot of different options. But typically, if you're at a CAR T center, they should be very well versed at trying to make sure that those things work out well for you.
Are CAR T cells easier to extract than stem cells?
So easier is a tough I wouldn't say easier or harder because stem cells are a part of your body the same way T cells. So for example, um, T cells are the main soldiers that fight off infection. Okay. The only thing that we're doing is taking those T cells and say, hey, you guys are great soldiers. Let's just change the target. And instead of fighting off infection or COVID or some of those things, let's fight off cancer. And let's teach, and we unfortunately have to teach them how to do that. So that's why the process of CAR T isn't something that's immediate. It takes about 4 to 6 weeks for us to remove those cells and now change those regular immune system T cells into what we call CAR T cells, who are now ready to fight off cancer.
Why do you need so many lines of treatment before you can be eligible for CAR T cell therapy?
Yeah, that's a great question. So, what I'll say is, I'll use an analogy. All right. Several years ago, our world was shook with a global pandemic. All right. There were people from all over the country, all over the world who were affected by this. The good news is that we found a vaccine. And so when the vaccines first came out, as you remember, they weren't available for everyone right away. Who did they go to? The people who needed them the most. And so those are typically people with a low immune system, people who are elderly. And we knew that those are the people who needed the most help. But over time, what happened? It became more and more and more available. The same thing is true for CAR T. This CAR T is very new. So who did we offer it first to? The people who unfortunately ran out of lines, who didn't have any other treatment options. And so, as we know, the FDA recently just approved it to be used earlier lines of therapy. And what will probably continue to happen is that they'll continue to make it more and more and more available. But again, you have to remember CAR T compared to some of these other medicines is still only in its infancy.
Good. Last question is, how soon should a bone marrow biopsy be conducted after a transplant?
Yeah, great question. So each institution that does stem cell transplant has their own protocol, but most places do it somewhere around the 3 month mark. And so that's typically where, because you don't want to do it too early, because we know that stem cell transplant can really kind of wipe out the bone marrow, but you don't want to do it too late because typically the next step after transplant is maintenance. And you want to kind of get back on maintenance within a 3 to 6 month period. So typically around that 3 month area is when most places do the bone marrow biopsy after transplant.